minutes because I forgot, so I'll just do it now. All right. So I will share my screen while we wait for everybody. Cool. There you go. Show up all right, Chris?
Yep, perfect. You're good.
I'll launch that poll. Do you guys see the poll on your side through my screen? Like, does it show my?
No, I don't. The poll hasn't popped up yet.
There we go.
Now we're good.
All right. We'll just wait a couple more minutes to give everybody a chance to sign in and whatnot, and then we'll get started. And today we're talking about heel pain, plantar fasciitis. It's kind of our topic today. For the people answering that poll, on question 3, it says if you've attended one or not. A couple of you guys have said this is your first one. You guys mind kind of throwing out in the chat box where your name and where you're from, and so we can give you a welcome, okay, so we know our audience a little bit. Nice. Morning, Jarek. Thanks for coming back. Brian, nice to meet you. Awesome. Cool. Adrian, Haley, Tracy. Hey, guys. Thanks for joining, guys. Appreciate it. Sarah from Connecticut. Nice. Cool. All right. So I'm going to close this out real quick. Okay. All right. So for those that use this, this is your first time, my name is Dr. LeMoine. I've been a physical therapist for about 12 years. Besides treating in the clinic, outpatient orthopedic and sports, I also teach at a university, orthopedics. Yeah, so welcome. Today, this will be our second foot and ankle session out of 3, right? So last week we did everything about Achilles, right? And kind of it comes down to a lot of just loading the tendon appropriately, right? That was the big takeaway, hopefully, from last week, is identify, is this really a tendinosis problem, mid-substance, and address it. Today, we're going to talk about heel pain, right? So better known as plantar fasciitis. They did a guideline first in 2008, right? And so the reason why they did it so early is one of the first guidelines that actually came out besides low back, because plantar fasciitis is the most common foot and ankle condition seen in the clinic, right? They did a survey of a bunch of therapists, and all across the board, 100% of them said plantar fasciitis was the most common ankle foot condition seen in the clinic. That being said, do you think that is the most common ankle and foot condition? Is that the most common foot problem, or is just the most common one seen in the clinic? What do you guys think? Do you guys think there's a more common ankle foot condition besides plantar fasciitis, just in general?
Ankle sprain.
Yeah. Ankle sprain, way more common. However, not seen in the clinic, right? People kind of can get better by themselves, a little bit of rest, right? They follow the RICE or the PRICE or the police. Now it's police is a new acronym, right, for resting and whatnot. Yeah, so they follow that and go through it. All right, so in this new guideline that they updated in 2014, they kind of were able to give grades to all the different evidence, right? So the nice thing is, yes, there's evidence for things, but the evidence isn't always equal. So at the end, we might come back and revisit what some of these that are kind of like A's and then what some are B's. And then what are some of the F's? Right? All right, cool. So did the PhysioU slide pop up for you guys? Can I see that? Yeah, perfect. Okay,
Yeah,
so
we're looking good.
clinical pattern recognition. You'd think by my sixth one I'd have this down, right? All right. So ankle foot, right? Clinical pattern recognition. If we click on our pain pattern, so if we're thinking if someone comes in with heel pain, right? What are our differentials? What are some, besides the obvious one, because we're talking about it, plantar fasciitis, what are some other ones that would kind of be pop in your head? Go ahead and type it into the chat box about what are some potential options.
Tarsal tunnel syndrome.
Yeah, tarsal tunnel.
Medial plantar nerve lesions.
Okay, so we got two things for nerve. Okay, so both of those are more of a peripheral nerve, right? A plantar nerve or a tibial nerve, right? What else?
Sesamoiditis.
Okay. Right. How about if I threw out that there was a trauma? I jumped off the second floor of my balcony, landed on my feet.
Calcaneal fracture, and we have PVD.
Okay, good. So yeah, based on other information besides just body chart, which is the nice thing about subjective, we get a lot. It tells us different options, right? So
Sever's disease.
okay, yeah. So you start to think some degenerative tendon insertions, right? So stuff that kind of goes on that we talked about last week a little bit. Good. So now if I do think it's the most common one for heel pain, plantar fasciitis, what else would be a big piece of subjective information that you might expect to hear in your subjective? So think subjective only.
First step in the morning is painful. Pain in the morning.
Yep, good. And with that pain in the morning, right, that's kind of one of the key findings actually for plantar fasciitis. It has a subjective component that, I get out of bed, it's the worst, first steps in the morning. What about those first steps? Is it something that eventually gets better, gets worse, stays the same?
It's better.
Yeah, it gets better, right? Something that gets better within how many steps do you guys think? Is this something that takes, 30 minutes to warm up?
Gabriella said a couple steps. We have just once you start moving.
The idea is it should be less than 15 steps. So if someone says, man, I get up, I walk in the morning, and my first steps are painful, and it takes, it takes a good 5 minutes of walking around to feel better, then we might think of maybe there's a different type of tendinitis or different type of arthritic change versus plantar fasciitis, where really, that first step, which pulls on that plantar fascia, which pulls on that calcaneal tubercle, severe pain, opens up an inflammatory response. But then after you've done it a couple times, it's okay. It's back to normal. That doesn't mean the pain goes away. It just means those severe steps are much better. So good. So we look for that in the morning. Good. As one of the key things. The other component would be as they go and continue on to activity, then it starts to increase again. So you kind of have this severe in the morning, better within 10 to 15 steps. But then if I walk for more than a half hour, right, it starts to bother me. So you kind of have this initial, gets better, and then overuse. Is there another finding that often people complain about, a subjective problem that say, oh, it hurts besides the morning one, which you guys all nailed? Awesome.
Jared said, due to a change in activity, increased activity may aggravate it.
Yep. Okay, good. Yep. So someone who all of a sudden started a walking program, someone who you know, went for a hike. So kind of this overuse, right?
Also prolonged standing.
Prolonged standing in place, right? There's another big one besides first steps in the morning. It's steps after prolonged sitting, right? So you kind of think about, I go and I watch a movie, first steps, I get up, same thing, 10 to 15 steps. Right, so any time of inactivity, and then you go and you walk on it. Good. So those would be like subjective complaints for plantar fasciitis. Some of our differentials, right? We talked about red flags. So you guys threw out calcaneus, fracture. I hear some stuff about arterial or vascular problems, DVTs. We want to think about diabetic neuropathy, right? Sometimes it can be painful on the sole of your foot with diabetes. If somebody has a problem that you think this might be related to diabetes, you think it might be related to vascular issues, what would be a finding that might help differentiate that from plantar fasciitis? So you know what, maybe this isn't a musculoskeletal problem, and maybe this is a vascular or systemic problem. What might be something that would help us in that realm?
Swelling, pedal pulse, calluses, ABI.
Okay. Yep. So good. So a lot of those are like things we pick up in our objectives. So observing for swelling, palpating pedal pulse, testing our vasculars. How about just when we're talking to them? Is there anything that just within our discussion or conversation that might say, you know, normally plantar fasciitis doesn't respond like, or doesn't act like that?
We have hair loss, cold limbs, sensation loss, history of diabetes.
Perfect. Good. Good. So talking about their current health in general. Do you have diabetes? Do you have a family history of heart problems? A big one is age, right? They talk about over 45 males, 55 females with health conditions, cardiac conditions, are more likely to get lower extremity issues, right? So you think about this peripheral arterial disease, stuff like that. So age is a big one. There's one other one I'm looking for.
We also had BMI.
Okay, so BMI, right? Unfortunately, BMI can do both, right? BMI is a risk factor for plantar fasciitis. So higher than 30 means you're more likely to get plantar fasciitis, but also higher BMI means you're more likely to have cardiovascular issues as well. So that's kind of one that goes down both. Is plantar fasciitis normally ipsilateral, bilateral, one leg, two legs? What do you think?
Unilateral.
Yeah, normally it's unilateral, right? Most of the time it's unilateral. If it is bilateral, is that pain at the exact same time together, or is it more only when you step on that foot, step on that foot? So the kind of pain would be different because it's very mechanical, right? Versus someone with a cardiovascular problem where the problem's actually up above, it may not necessarily be, they'd come together. We'd expect it to be kind of, if it's diabetes, you think of this glove and stocking distribution, the pain's equal on both sides. Even when I get off of it, I still feel it. So you kind of start to pick up on body chart, AGS, eases. And a lot of that will help you rule out some of these, what we would call red flags, right? Stuff that are treated by other people better. Good. Okay. So now if we go on to our other differentials, like the nerve stuff, right? I know you guys threw out tarsal tunnel and plantar nerve. What would be some of the objective tests that we would do to rule that out? Right? How do you rule out a plantar neuropathy?
Nerve tension.
Yeah. What nerve tension we thinking? J-Ho, what are you thinking, man?
Straight leg raise.
Okay. Would you put a bias on that straight leg raise?
To dorsiflexion eversion.
Nice. Good. Okay. Yeah. So it comes off of the tibial nerve, right? Medial and lateral plantar nerves. So we think of the tibial nerve, right? So dorsiflexion eversion, because it goes through the medial side of the foot. So good. So we can pull that up, right? There are some people that talk about adding like big toe and forefoot rotations to try to get more of the plantar nerve aspect than just the tibial nerve. But yeah, if you're crank on the tibial nerve, put the big toe in extension as well, you're going to get the plantar nerves. All right, so good. So we can try to do a tension test. if it's low irritability, right, I do a straight leg raise with a tibial nerve bias, low irritability, doesn't really pick it up. Is there something else we can do to be a little bit more sure that it's not a nerve? I'm not convinced that the straight leg raise was enough.
We also have Tinel and a sharp dull test.
Okay, good. So sharp dull, again, we're trying to implicate, is there a nerve problem, right? If it's truly plantar fasciitis and there's no nerve, we shouldn't have any type of issue with differentiating between sharp and dull and stuff like that. Tinel, we're looking for pain. So again, reproduction. If we tap into the tarsal tunnel, right, we expect it to kind of hurt where you tap. It's not necessarily the most comfortable, but what are we looking for? If I'm tapping in the tarsal tunnel, I'm looking for, does it reproduce into the calcaneus? Does that bring on your pain that you get when you walk? Good. Okay. Right. How about, again, so we go back to straight leg raise. It's, you know, he feels it. He's not quite sure if it's his pain or not quite sure if it's different than the other side. Maybe it was just he felt calf. How do I ramp it up? How do I be more aggressive than a straight
We have
leg?
add a net flexion to the tension test.
Okay. Okay. So we can add one more component distally, so up at the cervical spine. Is there another test that kind of utilizes more body regions than just adding the neck?
Slump.
Yeah. Right. We can slump them. Right. Some add that tibial bias just like we did in straight leg raise, and then it really lets us know, like, hey, okay, that's negative. Then it means there can't be any nerve tension issue, right? Because everyone should feel something with a slump. Right? Good. Okay. All right. So now let's go down plantar fasciitis. Right. So that's, I mean, we've kind of ruled out our nerve stuff. We've palpated, Tinelled, straight leg raised them, didn't bring it on. We've chatted with them, hurts in the morning. We're really going down this route. So prevalence, right? Kind of that just talks about, again, this being the most common condition seen in the clinic regarding the ankle and foot, not the most common problem. Just we see it more than ankle sprains because they don't come in. It talks about having a high BMI is a risk factor. It talks about an increase in activity all of a sudden is a risk factor, right? What are the tests that we'd want to do? So physical exam. If I want to rule in plantar fasciitis, what are some of the key tests I'd want to do?
Windlass mechanism.
Okay. All right, so we can do windlass mechanism. Good. What else?
We have range of motion, MMT.
Okay. If we're going to do range of motion, is there a particular joint or direction that we should be concerned about? Same thing with MMT. Is there a particular muscle we should be concerned about?
Jared said dorsiflexion.
Okay. Yep. Dorsiflexion.
Then Brian said endurance test as well.
Endurance test of what? What are you thinking, Brian? What muscle we doing endurance of?
He was thinking to get symptoms arise.
Okay. All right. So endurance, like, are you thinking like repeated calf raises, endurance, repeated posterior tib testing? I guess there's a lot of different ways.
He said 6-minute walk.
Oh, okay, cool. Yeah. So that would be a great outcome measure. Yeah. So awesome. Doing some type of outcome measure to find that doesn't necessarily help diagnose it's plantar fasciitis. It could be any type of problem, but it gives us a good correlation for next time we treat him. Is he getting better or worse, or is she getting better or worse? Right. So that's awesome, actually. So it's a good way to think of it as an objective asterisk sign that just gives us a measurement of where they are currently. Whatever we do for treatment, are they getting better, or did we make them worse possibly? So I like that. Good. So physical exam, our key findings, right? So key findings are, what are the things that are going to make it bring on his pain that help us feel more confident that it's plantar fasciitis, right? And so I definitely heard about windlass mechanism, right? Windlass mechanism is kind of done in two positions. You can do it supine on the table, so non-weight bearing, where you're just cranking the big toe into extension passively as much as you can. Or you can do it in weight bearing, where they stand off a step and their big toes hanging off the step, and then you just passively extend them as again. The goal of this is kind of two things. One, do they have the windlass mechanism? Meaning when I extend the big toe, does it pull on them and create some type of arch in their foot? It should, right? If everybody pulls on their big toe, right, you should see that your arch should get a little bit bigger, and you should feel like a rope under the medial longitudinal arch. right? So if everybody kind of reaches down and does that, you should feel that would be normal, right? So we're not looking for, oh, hey, it created a tension in their arch. What we're looking for a positive test would be, does that bring on their heel pain, right? And so I'd say in supine, when they're non-weight bearing and we crank on it, you're going to hopefully get enough motion to create the tension, but often that's not enough to really bring on their pain, right? Because I know that if I have a guy that weighs 200 pounds and it hurts when he stands on it, 200 pounds, I can't pull his big toe 200 pounds to create enough tension. So I would say that test isn't always the best for reproducing pain, versus in standing, they already have their weight on it, right? We pull on it, it's more likely to be painful. So again, we're doing this test for two different things, right? One is for actually, do they get the mechanism? And the other one is for, does it hurt? Does it bring on their pain, right? If you look at it, if it's negative, right? Sensitivity negative, that doesn't necessarily mean that they don't have it. It's really low. So it's good for positivity, specificity. So if it's positive, rule it in, right? But if it's negative, like I said, doesn't mean they don't have it. It means maybe we just can't pull as much as they weigh, right? So think of it kind of that way, right? Besides windlass mechanism, we want to be able to palpate where the plantar fascia inserts into. So again, if you go to the heel of your foot, right, the sole of your foot, there is a bone that you should be able to feel on the medial calcaneus, right? You have a medial tubercle, lateral tubercle. The medial one, that insertion is a bony place. That's where you're looking for it to be reproduction of symptoms, right? So it's kind of considered a key finding to bring it on, right? And I know a couple of you guys threw out, we should look at range of motion. We should look at MMTs. Agreed. We should look for, because this is an ankle and foot problem, we always do like our general, hey, let's look at active range, let's look at overpressure, because we're looking for impairments as well as reproduction of symptoms to see is it diagnostically correct. But most ankle range of motions aren't going to bring on symptoms because none of them directly pull on the plantar fasciitis, but we are looking for impairments. And one of the key impairments is a lack of dorsiflexion. Right? Good. Okay. So there's not too many tests that you need to do to rule in plantar fasciitis, right? Because a lot of it you already have from subjective. Hey, it hurts right here on my heel with my first 10 steps in the morning. Okay, you probably have plantar fasciitis. Let me do my windlass. Let me push on it. Hey, it hurts. Okay, I'm pretty confident it's plantar fasciitis. Let me rule out my other stuff, right? Good. Okay, so if we move away from key findings, what are we going to do for treatment, right? You know what? Hey, you have plantar fasciitis. If I go see a podiatrist, they can diagnose that within 2 minutes, and they can send me out the door within 7 minutes with a treatment, right? What do you think that is? What's the most common kind of just go-to for plantar fasciitis?
Orthotics.
Okay, orthotics.
Taping.
Taping. Okay, you guys are thinking like physical therapists. Don't think like a physical therapist.
Tennis ball roll.
Yeah. All right. What else?
Rest.
Rest.
Ice bottle.
Yep. Good. So those are all the typical.
Stretch.
Yeah. So if you were to go and see a podiatrist or look on Google or anything, right, you're going to come across, right? You're going to come across all of these just typical, do a lacrosse ball, do a frozen water bottle, sleep with a calf stretch thing on, right? Now it's all about shockwave therapy, right? A lot of podiatrists are doing shockwave therapy. Do it. So
Are they doing injections too?
no, they don't really do injections as the first case. Like now, if it's someone that's chronic, they've gone through it a lot, they will. They try not to inject areas where you put a lot of weight on it, like the seal, because of risk of infection and because of fat pad irritation. So it's a common place. So not that they don't do it, it's just not early. It's more like, hey, I've tried this and this and this. It's still there. I've had this for 6 months now. Then they'll do injections. Good. Good. Okay, so that would be kind of the typical, and really we would call that symptom management. You know what, we're going to roll our foot on the ice bottle because it hurts. There's some inflammation. Let's work on decreasing that. Your plantar fascia, we think is, in their mind, their plantar fascia is getting tight. So we're going to roll it out like soft tissue, just like you would roll out your pec or you roll out your quad, right? So that's kind of what the thought is with that, right? So now you guys, which you've already stated, right? If we're going to, physical therapists or PTAs going forward, we want to be able to say, hey, can we do more than just address the symptoms, right? So can we do more than just roll our foot on a bottle? Can we actually go after why they have plantar fasciitis, right? And so that's kind of where we'll talk about these movement faults and associated impairments, right? So what do you think is one of the key movement faults or one of the key impairments for why people get plantar fasciitis?
Overpronation,
Yep.
lack of range of motion in the gastroc, lack of dorsiflexion.
Yep. Good. Perfect. All right. And those are the two biggest ones, right? A lack of dorsiflexion and someone who has too much pronation or they don't resupinate. Can you guys talk, anybody, right? Can you guys talk about how a lack of dorsiflexion can cause someone to have irritation of their plantar fasciitis or the insertion of the plantar? Like, how does that correlate? How does me stretching and then giving them more dorsiflexion helpful?
Pulls on the calcaneus, less stiff plantar flexors, reduces the time it's shortened.
Okay, good. Okay. So we often think of plantar fasciitis, right? If this is my calcaneus, right? We think of plantar fasciitis as it's always pulling from the distal part where the big toe is, pulling on the medial calcaneal tuberous, right? But if you think about it from the back side of your Achilles, it attaches down to the calcaneus as well. So even though we call it plantar fasciitis, really you have the same amount of pull coming from the Achilles. It still comes down and attaches to the undersurface of the calcaneus. So if someone has a really stiff gastroc and it's always pulling on it, right? Yeah, you're going to tend to get more irritation at that insertion point. So that's definitely something we want to try to improve is can we decrease the amount of tone and pull at that site? So yeah, so working on calf mobility. So soft tissue of the gastroc, contract, relax, stretching of the gastroc, all that stuff. The other thing would be if someone lacks dorsiflexion, right? I'm standing all the time. I stand as a job. If I lack dorsiflexion, am I going to have more weight on my heel or more weight on my toe typically? Forefoot or rear foot?
Forefoot.
Think about not going into a squat, not walking, but just standing. If I lack dorsiflexion.
Now we have rear foot.
Yeah. So when I'm walking, you're right. My heel's going to come up early and put more weight on my forefoot, right? Think about someone walking on their toes. They lack dorsiflexion. So, but if I'm standing, I'm not going to just stand on my toes, right? Like take some balance. I'm going to stand flat-footed. But because I lack dorsiflexion, my tibia will be a little bit more backwards, right? Think about with dorsiflexion, my tibia goes forward. Think of a squat, right? So I'm going to actually be leaning back a little bit more. So that puts more weight. So think about just standing all the time. If I don't have dorsiflexion, I'm going to be just on my heel more. Do you think that can irritate that medial calcaneal tubercle? Yeah. So good. There's one more. So now let's take away gastroc, right? We take away the lack of dorsiflexion from the gastroc. What about like a lack of dorsiflexion from the talocrural joint? How can that lead to increased irritation of the plantar fascia or the insertion site? If you guys were here last week, think about what happens when you lack dorsiflexion.
Compensate pronation due to a triplanar motion.
Cool. Awesome. Yeah.
Less mobility proximally causes excessive mobility distal.
Good. Yep. I agree with both of those. Yep. We need to be able to move in the sagittal plane, right? Talocrural motion, dorsiflexion is sagittal going forward. As I walk, as I squat, as I lunge, as I go downstairs, if I don't have the ability to go into dorsiflexion, right? Talus going posterior glide, then I'm going to figure it out somewhere else, right? So instead of doing a posterior glide, I'm going to tend to overpronate to compensate. So I'm going to roll through that medial longitudinal arch, medial longitudinal arch. If I continue to do that over and over and over, that puts a lot more strain on that passive support. The fascia is a passive support, right? So it's always pulling on it, which then leads to irritation. Right? So if that's the case, where I'm overpronating, maybe dorsiflexion is the reason why. So I might have to work on mobilizing dorsiflexion to allow them to move normally so they don't have to compensate, right? But remember, there's also people that have plenty of dorsiflexion, no issue with dorsiflexion, and they overpronate as well, right? So we might need to say, you know what? We checked their dorsiflexion, it's good. Now we're gonna work on the arch stuff, right? How would you guys check their dorsiflexion?
Cover with అనుకోండి.
How would you guys check their dorsiflexion?
Functional squat or goniometer.
Okay. I like the idea of doing a functional squat because it tells us how their foot moves with function. So if they squat and they move into dorsiflexion, fantastic. If they don't have it and they compensate and they pronate, it might be painful. That gives us the perfect opportunity to try to correct it. So, right, we watch them squat, we try to correct it. That doesn't, unfortunately, that doesn't necessarily give us a number per se about, or do they have enough dorsiflexion? Is it different than the other side? So there's kind of a test out there that's really
Yeah,
well
the
done.
needle wall test.
Perfect. Good job. Right. So that test is considered highly reliable and specific for weight-bearing dorsiflexion measurements, right? Better than the table where we try to push them into dorsiflexion because, again, they weigh 200 pounds. It's hard to push someone's foot 200 pounds and then measure it with a goni at the same time. So I like the idea of being weight-bearing. The squat is very functional. It tells us how they move. Needle wall gives us actually a number with a goni or measuring tape measure. And you know what? That they have enough or they don't have enough, and I should do it. The good thing about that as well, kind of like the squat, if it hurts, they squat down and they get their pain in their heel and they pronated a lot, that gives us an opportunity to change it, right? We can try to put something under their foot and correct their arch and have them redo it to see if it changes their pain. If it does, that kind of makes us a little bit more confident that, hey, we should work on arch control. And so under our movement faults, we have this excessive midfoot pronation. So watching them squat, do they overpronate? Watching them walk, right? From a side view, right? If we're looking at arch, we want to see a side view. And even just look at them getting them up and down out of a chair, right? Another movement fault would be maybe it's coming from up above. Maybe the reason they're pronating a lot is because their femur is diving in. Right? If I have really weak glute med, glute max, poor coordination up above, and my legs diving in, my femur's going into internal rotation, that automatically puts more weight on the medial side of my foot. So I need to be able to control my arch even more. So maybe we need to work up the chain, just like you think about with patellofemoral pain, right? Same thing. However, how do you know we should spend time on that, right? Think about, there's all these things we want to work on. The further we get away from the foot, sometimes the harder it is to make that sell to patients, right? I know your foot hurts way down here, but we're going to have you work on glute strengthening to help it, right? How do we make that connection for them? Or how do we decide for ourselves, is it worth it?
Check if their hips are anteverted.
Okay. Yeah. So we can look.
Glute med MMT.
Okay. So glute med MMT.
Check genu values with single leg squat.
Okay, good. So I would say I would probably start with something more functional like that, have them do something. And if they have a lot of femoral internal rotation, they have a lot of collapse, then that tells me I may want to look at stuff on the table, such as a Craig's test for anteversion. I want to look at a glute med test for T. So I would go down that route if I really see it in what they're telling me hurts. Man, it really hurts when I'm going downstairs. Show me that stair test or show me that single limb squat. Now, if they show me and they don't dive in, then I'm not going to spend time looking at glute strengthening. I'm not going to spend time looking at Craig's test because I know there's a lot of other fish to catch around the ankle and foot, right? So it's a good screening time. It's a good time to screen for things with our functional exam, right? So we've done squat, single limb squat. We've watched them walk, and we get an idea of where do we invest our time. Good. Okay. So those would be our movement faults that we kind of would want to assess. How about associated impairments, right? So we've talked about a lack of dorsiflexion, right? How that can correlate to increased plantar fascia stress. We've talked about excessive pronation, right? And how that can correlate to this overpronation stretch or this stresses on the plantar fascia. What would be some of the key tests to look at midfoot mobility? So now you know what? I saw them walk. They had a lot of pronation. I watched them squat and I saw they had a lot of pronation and it hurt. I want to be able to measure that just like we did with dorsiflexion knee to wall. Is there any test that you'd want to do to actually measure?
Navicular drop test.
Nice, navicular drop test. What else?
TN PAM.
Mm,
Fice's line.
all right, Vice's line, yep.
JO said draw the foot.
Draw the foot. What do you, I'm not quite sure what you mean by draw the foot. Like trace it, outline it?
Yes.
Okay. So the guideline uses 3 different measurements as the ones for like looking at arch height, right? Right. And one of them was navicular drop test, right? Another one is called arch height ratio, right? And so what you're doing with arch height ratio, you're just measuring from calcaneus to either the longest toe or what's considered truncated, the ball of the foot. So you measure like the length of it, you find halfway, put a dot on the navicular, and then you just measure and you create a ratio, right? However, if you look at the sensitivity, specificity, likelihood ratio, there's none, right? So in general, this test isn't the best. There's no real numbers to it, which is why they've kind of clumped these together, right? Because even with the navicular, there's no real numbers to it as far as how good of a test it is, right? With the navicular drop test, remember you're finding the most inferior part of the navicular, you're putting their foot in subtalar neutral, right? And you measure how many millimeters it is to the floor, right? And then what you do is you put them into relaxed foot. So first subtalar neutral, I measure, now stand relaxed, measure again, right? You're looking for how much does it drop. It should drop some, right? What's considered normal, right? If you're reading a case study and someone says, oh, they had a navicular drop test of blank millimeters, you want to know, well, is that good or is that bad? What would be considered normal?
6 to 8 millimeters.
Nice, good. Yeah, so that's normal. So if someone says navicular drop test of 6 millimeters, you're saying, oh, that's not a positive test. But if it's 14 millimeters, yep, good. All right, there's one other one they use, and that's your longitudinal arch angle, right? And here they're measuring from the medial malleolus, the navicular, to kind of the distal part or the proximal part of the first phalanx. And so they're just creating an angle, and they're kind of saying around 120-ish. Anything over 120 is considered like too much of an angle. And again, the numbers for it, sensitivity, specificity, there's none, right? There's no articles that support this as a good test by itself. So I kind of think of these arch tests as you're kind of giving yourself a number to be able to compare it to the other side, right? You're giving yourself a number to be able to correlate to what's considered normal, just to be able to say for next time, is it any different versus being very subjective? Otherwise, if you look at it, a lot of people have flat feet, a lot of people have bad arches. How do we know if it's changing or not changing? So it gives them, but the research says you should do these as a clump of 3 because of the fact they're not really good tests by themselves, right? So you have arch height.
Dr. LeMoine, kind of going off of that, I just have a question. Just for time-wise, with having to go through all these different tests for plantar fasciitis, which one out of you usually do all 3, or is it one you kind of just go for one?
No, I normally go for one, and it kind of depends on if they have a really rear foot eversion and their navicular bone is like sticking out a lot, right? I'll do the angle. I'll just measure it with a goniometer, where I'll do the longitudinal arch angle measurement, right?
Got it.
Versus if it's more of a midfoot, like their rear foot calcaneus is actually pretty neutral, right? Meaning I can adjust their midfoot kind of easily. I'll do navicular arch.
Okay.
So, and I think if we were here last time, we talked about someone who's really pronated. It could be driven from the calcaneus, from the subtalar joint, right? If this is my calcaneus, if I'm super everted, the whole forefoot's going to follow that, right? Versus people may have a normal calcaneus, straight up and down, Achilles is straight up and down, and then it's all from the midfoot, right? So kind of, if you can identify this is a rear foot driving the pronation or it's a midfoot driving the pronation, it kind of gives you a little bit of maybe a little guidance on what you want to do for intervention to where you might get more bang for your buck. Right? But I would say the easiest to do is navicular drop, because I don't have to measure anything or do anything. It's only one measurement versus having to make dots and measure again. So it's the quickest. But I realize if someone has a really rear foot problem, it doesn't change. So because it doesn't change, I'm kind of like, well, I'm not going to measure it. It doesn't do anything versus maybe I can get the arch angle to change. Right?
Got it.
Good. I would say one of the importance I see in this is for patient buy-in. So if I'm measuring their non-painful side and I measure it and it's like, hey, this is 128 degrees, and then this one is 121, it gives them a difference to be like, hey, it's different. This is why you possibly have pain. Because what do you think a common complaint is when I say, oh, the reason why your foot hurts is because you're really pronated on that side? What do you think I hear often?
I was born like this.
Yeah, you see my other foot? My other foot looks exactly the same, right? So we're trying to convince them that the reason it hurts is because of this thing that you have. And it's the same on the other side, but that side doesn't hurt, right? So it's trying to find a number that's different, just like doing like a quad strength for a post-op ACL, giving them a number. Hey, this is 100 pounds. This one's only 80 pounds. It kind of motivates them to do stuff sometimes, right? People are kind of competitive like that. Okay, so those tests give us a number. It kind of tells us what we already know, that you're pronated, right? And now if we're going to work on strengthening, right, we want to be able to MMT certain muscles, right? What muscles would we want to MMT the most, you think?
Post-tib.
Post-tib, good.
Tibialis anterior, peroneus longus.
Good. Okay, so we have some medial muscles, post-tib, anterior tib. We got lateral muscles, peroneus longus. How about intrinsics? Right. We know that extrinsics, the ones you guys just named, have a little bit more influence because they have longer pulls. But how about intrinsic muscles? Are there any intrinsic muscles that can assist with supination or a good arch? Think back to when you guys were all in clinic and someone has foot problems. What's a common foot exercise that you guys probably, if you were ever AIDS or that you had people working on?
Dina said plantaris. Alyssa says domi. Brian says toe scrunches.
Yeah. So doming would affect more the arch. If we're looking for actually muscles, right? The toe scrunch, what does the toe scrunch do the most of?
We have an anatomy answer, flexor digitorum brevis.
Okay, yeah. So I think we went from the exercise to a very specific muscle, maybe in the middle. We're looking for toe flexors, right? So good job. The idea is if we can strengthen the flexors of the toes, those can assist it. Those are the intrinsic ones. One of those being flexor digitorum brevis. Yes, good job. To work on that. So there are other ones in there as well. And the idea is, can we get those muscles to support the arch, right? Okay, so we've talked about extrinsic muscles. How do we test peroneus longus? If we're going to MMT it, what would be the position we'd put the foot in to test peroneus longus?
Eversion.
Okay, so eversion tests the peroneals, right? Doesn't differentiate between longus and brevis. Brevis does not affect the arch because it doesn't wrap under the foot. The longus does. So how can I differentiate between peroneus longus versus peroneus brevis?
Plantar flexion plus eversion.
Good. Yeah. So if we put in plantar flexion, that focuses on the longest, which is the one that wraps around. How about post tib? How would I MMT post tib?
Plantar flexion inversion.
Nice. Good. Perfect. Awesome. Okay. So we've looked at functional stuff. Let's see where we're at. We talked to them subjectively, identified plantar fasciitis, probably. We've ruled out any nerve stuff. We've ruled out any cardiovascular stuff. We've palpated the tubercle to make sure, yep, that hurts. We've done a windlass mechanism. We've looked at functional stuff like knee to wall for dorsiflexion, squat, gait. We've looked at all of our arch measurements. We've MMT'd the arch muscles. Right? If we wanted to do some accessory mobility testing, so if we want to do longitudinal or mid-tarsal, if we want to look at arch, we're looking to see, does the arch even lock up, right? So if I take someone and I supinate them all the way at the calcaneus, right? So I pull it into inversion, right? I can then try to move the medial longitudinal arch or the oblique axis, right? I'm trying to move these. What am I looking for, right? What's the importance of maybe doing this test? It's not functional. It doesn't tell me how strong they are. What's the benefit of looking at these mid-tarsal joint axes? Because in the guidelines,
Joint mobility is or isn't there.
okay, because the guidelines say we should look at them, right? And what would we expect to find for someone with plantar fasciitis? And we're doing this, what would we expect to find?
Decreased mobility.
Okay,
Navicular is stuck up.
stuck up. If it's stuck up, you mean like towards the, not plantar, but like the ventral part of the foot? Are we thinking like it's stuck in supination?
She says ventral.
Okay. So we think about if we have plantar fasciitis, it's associated with excessive pronation, right? So meaning navicular drop to the floor, right? Position, right? So when we are wiggling someone's foot, pronation is considered the open pack, right? So the calcaneus would be in eversion. So I put the calcaneus in eversion and I wiggle, it should be unlocked. Right? That would be considered normal, right? If I supinate it, meaning I invert the calcaneus, right? Invert it and I wiggle, it should be in a locked position, right? So I'm giving someone stability by inverting the calcaneus as much as I can. And then I try to move that axis, right? We're looking for, does it lock up? Meaning, is there less motion than when it's everted, right? If we're thinking plantar fasciitis and they have too much pronation, we'd expect that when I supinate it, it maybe doesn't lock up as well. It would be a little loose still. So we say, yes, this person has excessive motion on that mid-tarsal axis, right? How does that help us, right? How does that help us with treatment? If it's stiff, if it lacks motion, that's easy, right? If it's stiff, man, I pronated them or I everted them and it didn't unlock. It didn't move well. That's easy because we can just work on mobility, right? If you test something and it doesn't move well in that direction, treatment kind of matches that. You move it more into that direction, right? How about for someone who it doesn't lock up like it should? How does that help us with treatment?
Strengthening.
Yeah, tells us strengthening, right? We want to work on strengthening because it needs more support, right? Think of it like testing someone's, what would be like a anterior drawer for an ankle sprain. You check the anterior drawer, it's really, really loose, right? It doesn't lock up like it should. You say, oh, we're probably gonna have to work on stability and strengthening, right? So now I would say, let's take that a step farther, right? We supinate them maximally. We invert that calcaneus maximally with all of the strength that we have, hoping that it locks up. If we can't get it to lock up, are they going to be able to get strong enough to lock it up on their own, you think? Right. What it tells us is, even if we act as their muscles for them, right? I'm going to be their muscles. I'm going to do it for them, and it still doesn't get good lock. Are they going to be able to strengthen enough to get a good lock? Probably not, right? That doesn't mean we don't work on it, right? But it means that they might need more, right? What else? What would be the next? What else could we give this person to improve their ability to supinate? Because I can't supinate them even when I act as their muscles, right?
Need an orthotic.
Yeah, exactly. You know, it's like, now versus, let's go back to the guy who's pronated like crazy. We check this test, and if I supinate him like crazy, he locks up well. I'd be like, hey, this guy has the integrity to create a good arch. He doesn't have the strength to do it, but it's there. It's built in there because I could do it for him. Meaning this guy maybe doesn't need an orthotic. He just needs to get stronger. The person before, I can't even lock him up. I can't create supination well. He probably needs an orthotic, right? There's a standing test as well that kind of looks at the ability of what is the integrity of the arch, right, in function, and does it have the passive support, all those ligaments, and can he even create an arch? If his life depended on it, could he even create an arch? What do you guys think that test is? It's in standing.
Standing hip rotation.
Yeah, so standing trunk, hip rotation, right? Keep your feet down, you rotate all the way one way. The direction you rotate to should cause supination, right? If your foot doesn't come off the ground and you lock up everything, the whole idea is you're trying to lock up all of your ligaments and tendons and everything, and that lock should create supination. If it doesn't, then they're probably not going to get strong enough to ever create a good arch. So they need support. They need passive support. Good. Okay. So I think we've talked about this idea of looking at arches to nauseam a little bit. All right. We kind of go back. So we looked at all of our associated impairments. We looked at midfoot mobility. We looked at arch strength, right? We talked about looking at muscles up the chain if needed, right? How about if we look down the chain, right? What about big toe extension, right? If someone lacks big toe extension, right, then how does that affect their plantar fascia?
Shortens it.
Yeah, exactly. It doesn't get to go through its full length, meaning you don't necessarily get that passive support for your windlass mechanism, right? The windlass mechanism is actually helpful in creating passive support for the arch, right? Because can we strengthen our fascia? Is it a contractile tissue? No. So really it needs something to pull on it like a lever to create that tension, right? So if someone lacks big toe extension where they never get to that, then their plantar fasciitis is never going to help the arch, right? So we want to look to make sure, right? We look at it kind of in the windlass mechanism, but that's more of like, do they get pain? Yes or no? Does the mechanism work? Versus here on the table, we're just working on, do they have enough range passively, actively? Can they get at least past 70? Because that's what's needed for it. Ideally, passively for a young person, you should be able to get to over 90, 100 degrees of big toe extension passively, not actively, passively. Okay, so those are our parents. If I was going to now treatment, all right, so I go back, plantar fasciitis, let's go into interventions, all right, manual therapy. What would be some manual therapy things I can work on? Let's say we wanted to improve dorsiflexion. How would I improve dorsiflexion?
Soft tissue massage.
Okay, so soft tissue is one. Soft tissue to the gastroc soleus, right? What else?
Taylor crural modes, posterior glide.
Awesome. So hit the tail crural joint, posterior glide. What else? What other joint less often affected but can cause a decrease in dorsiflexion?
Distal tib fib joint.
Good. So a posterior glide at the distal tib fib. Good. All right. So those are perfect. How about if I wanted to improve mobility at the big toe?
Burst MTP joint moves post.
Okay. Am I going, which direction am I going? Is it concave or convex joint? If I'm trying to improve dorsiflexion, am I going to do a posterior glide or anterior glide?
We have dorsal glide.
Dorsal, okay. So it is a concave, meaning if I'm going into extension, I'm going to go right in the direction. So I'm going to do a anterior superior glide, depends if they're however you want to create gravity. Yep. Versus if I was trying to improve flexion, it'd be a posterior glide for flexion. So anterior glide for extension. Good. How about, so you guys got your stretching, hands-on stuff, you got your mobilizations. What about distractions, right? Taylor Cruel grade 5s for distractions, big toe extension or big toe traction, right? Remember, if it's joint stiffness, we can improve mobility through distraction, right? Good. Okay. So that'd be our manual therapy. All right, let's see what we got. So improve dorsiflexion, improve gastroc flexibility, improve first MTP extension. Good job, right? We talk about subtalar here. So subtalar meaning your calcaneus joint, right? If we think just biomechanically, what direction would I probably want to mobilize someone's calcaneus into if they have plantar fasciitis? Right? Medial glide or lateral glide? If you envision someone with really flat feet, try to envision looking at the back of them, what position is their calcaneus in?
Medial glide.
Exactly, yeah. We think of the calcaneus as everted, right? Everted, meaning we probably want to push it into inversion, which would be medial. Now, there's no articles that support that that's the case, right? It's just we think biomechanically, can we do that? Clinically, right, there's benefit to improving someone's subtalar joint if it's stiff. But I haven't found anything that says medial versus lateral. I try medial because it makes sense to me. But in the clinic, if it's stiff, I do medial, it doesn't work. I have no problem flipping them over and doing a lateral glide. And I've seen improvements in that as well, right? You're just trying to improve that 6 to 8 degrees of subtalar mobility, right? So you want to have some motion in that subtalar joint, right? But it makes sense to think about it biomechanically, like, oh, it should go that way, but we want motion, right? Remember, motion absorbs shock. If it's stiff and there's no shock absorption, something else going to do it for you, whether that's the Achilles above, plantar fascia below, right? So we're trying to help that. Good. So that's subtalar. All right. So if we go back from manual therapy, right? Actually, sorry, let's go back to manual therapy. Everything we just talked about was kind of like indirect to actually what hurts, right? We're working at distal, the big toe, proximal, the ankle, the calf. How about if we're working at the plantar fascia itself, right? We think the plantar fascia doesn't move well. It's getting a little degenerated. There's some degeneration in that fascia. We can do some fascial work directly on it, right? What would tell you that you might think about doing soft tissue mobilization to the plantar fascia? What would make you decide?
Soft tissue massage with plantar fascia, get those adhesions out. It feels bumpy compared to contralateral side.
Okay, good. So palpation, right? Just because someone has plantar fasciitis doesn't mean we go straight to soft tissue, what hurts. It's, hey, let me assess that tissue. If I compare it to the other side and I feel a bunch of restrictions and I feel a bunch of fibrosis, as they would call it, maybe we can improve that. So totally, I agree with that. Good, because we don't really want a soft tissue, the calcaneus insertion, right? There's no point in soft tissue in the bone that hurts, right? Yes, you'll have some placebo stuff, but really we want to work on the tissue that pulls on it. There's another reason why I might want to work on soft tissue to the plantar fascia.
Either for pain or poor locking.
Okay. We can do it for pain, right? We can definitely, I'd say there's probably better things to do. If it's just pain only, like, ow, it hurts when I palpate it. There's probably better things to do than soft tissue massage. But we would do soft tissue for, I think someone said adhesions. Why else do we do soft tissue?
Bring blood flow to the area.
Okay, so blood flow. Why were we going to soft tissue someone's calf earlier? What was our goal with that? Right.
To increase dorsiflexion.
So mobility, right? So if I check someone's dorsiflexion and they feel a big stretch in their calf, maybe I'd work on it, right? If I check someone's big toe extension, right? Hopefully they feel it in their toe, right? That's the end. If they feel a big stretch in their arch, hey, that tells me that they could use more mobility there. and maybe I will then go through and do soft tissue there, right? So all the things you guys said are correct in the fact that, yes, we can do it to increase blood flow. We can do it for pain control. It's great. But is there something that tells me I would get a better benefit out of this, right? Because yes, anytime you soft tissue and put your hands on people, they find benefit things. But it's like, hey, you know what? I'm doing this because A, I found a bunch of adhesions, or B, you know, they really lacked mobility. When I checked their range, it was limited because of not the big toe, but it was limited because of that fascia. Good. Okay. So that'd be our soft tissue. So that's kind of us working mobility, manual therapy. Now, if we're going to go to therapeutic exercise, right? All of our mobility can match. We can teach them to stretch their calf. We can teach them to self-soft tissue their plantar fascia. We can teach them to stretch their big toe. All right. We can kind of, those are the nicest. We can do one-to-one. Whatever we do in the clinic, we reassess, they feel better. You do that at home, right? So that's the nice thing about if we do manual therapy techniques for mobility. If we step away from mobility, now we're going to work on coordination, right? We're going to have to work on all of our strengthening, right? So this is kind of where it gets, this is where it gets a little interesting when we talk about plantar fasciitis, or even in general, arch strengthening, right? If I asked you guys to throw out different ways to strengthen someone's arches, we could probably create a list of 30 things, right? So let's start very low level. Let's start with someone who has no idea how to turn on their arch muscle at all. Right? No idea, right? Even when you MMT'd it, they don't even feel it in their arch. They feel their gastroc working. They're feeling, what would be something where it's like, hey, let's just get you to know how to, let's just get you to figure out how to even turn it on. What would be like our low level stuff?
Towel scrunches, NMES, marbles, toe scrunches.
Good. All right. Extra high five for whoever said NMES. That's awesome. Good. Right. So again, not often used in the clinic, but using NMES on those small arch muscles or putting it on maybe your post-tib, peroneus longus, definitely, right? There's some studies that have come out more recent that looks at using these neuromuscular re-education things. So good. So we can do that. Towel scrunches, it's good because it's called an external cue. Right? We're not telling them to create a nice arch or anything like that, which creates their brain. We're saying, hey, pick that up. I don't care how you do it. I don't care what muscles you're using. You're going to pick that up. And you can't use your calf muscles because it doesn't touch your toes. So it forces you to use something in your foot. So those are nice way. Now, does that create the nice, perfect doming of an arch? No, right? It doesn't create this nice functional arch, but it's a great way to them to just get in touch with where these muscles are, right? It's like kind of getting someone to figure out how to turn on their transverse abdominis sometimes, right? Where like just you spend them trying to get them to turn it on, right? The other thing would be is just kind of going open chain sometimes. So getting that TheraBand, right, and going into the plantar flexion inversion or plantar flexion eversion to really work on some of these directional stuff, right? They can work on holds. They can work on rhythmic stave in that direction where they're pulling with a TheraBand. All of these are low-level things to get them to turn it on. Okay? So we work on that if they need it. If someone doesn't need it, they don't need that component, we can skip it and we can get to more of the higher level stuff, right? Higher level meaning really standing weight bearing. We want to get to weight bearing, right? So what would be, so if we kind of come here to this foot strengthening, right? What we really want to work on is what's considered doming, right? What are some other ways you guys have heard it termed besides doming? Because I know we're coming from all different parts of the country. Everybody has different words for it.
Short foot.
Short foot, yep. Anybody else? Anybody heard of like the tripod? They call it tripod because you're trying to weight bear on heel, ball your foot, and then your lateral fifth, like you're trying to create this tripod thing. Yeah. Oops. I totally clicked on some stuff, didn't I? Let me go back to
Dr. LeMoine, we had a question.
Yep. Ask away.
How come when you're talking about the glides at the first MTP joint,
Yep.
and you say anterior glide, even though you're moving dorsal and plantar?
Hey, let me read. So when you're mobilizing the big toe, is that what you're talking about?
Yes.
Ask it again one more time.
Why is it called an anterior glide at the first MTP joint, but not a dorsal glide?
I think just terminology, it could be probably interchanged, but if you're standing in anatomical position, which is standing up, right? Superior would be towards the ceiling. So you could actually even call it a superior glide. If I'm in full plantar flexion, anterior would be towards the ceiling if I'm supine. So I don't know if it really makes a big difference in the term as long as you're going into the direction. So if I'm moving into extension, if this is extension for me, I'm going to mob in that direction because it's a concave joint, right? But the word of it, I guess it's hard to understand. I don't know why we would choose anterior versus dorsal, as long as we're not saying posterior plantar, because you could even call it superior technically, right? So it's kind of interchangeable. I don't have the best answer for that, I guess, on why the person that termed it that. We'll blame it on J-Ho. Okay. All right. Good question though. I like hard questions. Okay, so if we're talking about short foot, we did the low level stuff. Right now we're going up to higher level where, hey, they know how to turn it on, or they know where the muscle is. Now can we teach them to create a nice, good arch? So whether that's a short foot, whether that's a doming, whether that's a tripod, we want them to be able to create an arch in weight bearing. The earliest level will just be sitting, where majority of their weight's on their butt, right? You think about 80% is on their butt, but they do have some weight on their legs. They do get to feel the ground, and we try to create a short foot. What are the problems that you guys come across, or what do you expect to come across when you try to teach someone how to create a nice, beautiful arch? Right, so they're sitting in the chair, you keep telling them, right, create an arch, you're showing them with your foot. How do they compensate? What are the difficulties?
It's supinate, anterior tibs overactive, toes start to elevate, plantar flexion may occur, mid toe lifts up.
Okay, good. All those awesome. Yeah. I would say the most common one I see, right, is they just try to crunch with just their toes, and all of a sudden their whole ball of their foot's in the air now, right? So if this isn't here, let's see, we'll do this side. So they're just doing this to create an arch, right? Did they create an arch? Yeah. Did their arch go in the air? It sure did. But is that functional for when they walk? Are they going to walk on their toes? No. So it's never going to correlate and transition over. So we want to create an arch where their toes stay down, because that's your push off, right? So how do we create that? So that'd be the most common is, hey, I can get it in the air using those toe flexors, right? Which is maybe where we need to start with our marbles, but eventually we want the inchworm, right? So how do we get them? So that's on. The other common compensation is face for you. I say, hey, create an arch, and they just roll their foot out. Like, hey, look, I got my medial arch in the air. That's what you want, right, Doc? I got it up. Again, are they going to walk on the outside part of their foot? No, we want them to be able to put weight through their big toe. They should push off of their big toe. Right, so those would be the two biggest ones. The big toe coming up because they roll off, or it crunches. And I'd say there's times where I've spent 10 to 15 minutes just sitting on the floor, going over like almost like P&F stuff with them about like, this is a position. Can you hold this? Can you use this position, hold it? And then I'm doing it for them. And then we add a little, now you can hold it. Don't let me pull you out of that position. Let it go. Now you try it on your own, and they have no idea what to do. So we spend more time on just kind of this P&F stuff and eventually trying to get them. So there's a lot of different cues you can use, a lot of different handling thing to try to get them to hopefully leave that day knowing how to create a nice arch, right? So if they can do it in sitting, you then progress, right? Sitting to standing, to sit to stand motions, to trying to do like walking. Some articles talk about for your sports population, going into then hopping on 2 legs, hopping on 1 leg, doing a squat, a single limb squat, right? All these different activities based on whatever their goals are on how hard you need to challenge them. Can they keep this doming? Can they keep this short foot while they move, right? Good. Can you guys think of what are some cues or what are some tricks that you guys know to help get people to create a nice arch? You guys have any?
Airband sandal.
Okay, so there's little devices out there that can create different inputs into things.
Make the toes flat, then start doming.
Okay.
Pull up the arch towards the ceiling, but maintain that tripod.
Yeah, good. Okay. Yeah. There's a trick where if you put a TheraBand under someone's toes or under someone's ball of their foot, and then when they try to make it, if the ball comes up, then the TheraBand pops out, right? So they're put underneath and they're kind of holding it. And it's kind of like a feedback thing where they have to try to make an arch without letting go of it. Right, that's good.
Towel roll under arch.
Okay, yeah. You can stick something under the arch to put them in an arch. and then just tell them barely lift off of it, barely lift off of it, right? Because if you're already in an arch, there's not much more to go, but it's teaching them like, hey, this is the position you want. Can you take control of it off of that little towel, right? So that would kind of be like this end range, just getting them to hold that. Good. Another common one is if you put, like if this is, there we go. If this is their foot looking straight down, it's on the floor, and you put your fingers right at the tip of it, and you say, you know what, pull your foot away, and then you create this space, right? And and you say you can't bend your toes, so it has to come from the arch to pull away, and it gives them an external cue. Anytime you give someone external cues, all right, studies show that you have more benefit in them doing it correctly. Good, awesome. I'd say another one in standing is a good one. Is if you have someone walk, right? If my feet are farther apart, that puts more weight on the medial side, right? So I'm more likely to pronate if I walk with my feet in abduction, way far apart, right? If I walk a tightrope, right, it puts more of my weight on the lateral part, right? So I can say, hey, walk a tightrope. It makes them put more weight laterally, which is supination. But then I tell them, but keep your big toe down. So now they're fighting this line of, hey, I don't want to lose my balance. I keep my big toe down. And the idea is hopefully your arch in the middle will be the thing that's trying to fight from lateral to medial. So if you guys ever try it, try walking a tightrope, super slow, 1 foot in front, get your balance. Here, arch up, step, arch up, step, arch up. You just kind of walk down, and they're holding next to like a plinth or a wall. And hopefully you should start to feel your arches start to burn. Good. Good. And the nice thing is you don't really need much. I don't even tell them arch. I just say, walk a tightrope, don't let your big toe come up, right? And that's the idea of that. External, good. Okay, so there's all of our arch strengthening, right? Patient education, right? So if we talk about patient education, right, there is 2 patient perspectives that have been kind of published. So if we go here to our special patient education app, ankle foot, plantar fasciitis, good. All right, so here's one that talks about why does your heel hurt so much? What can you do about it? And it has the common exercises to work on improving mobility. JOSPT also has one on plantar fasciitis. Oops. Yeah, here we go. Guys, again, same thing. It's just a 1-page handout on plantar fasciitis and will physical therapy help? And again, they're working on improving dorsiflexion and improving big toe extension as kind of the main stuff. The nice thing about these, right, you can just send it, you can just do a straight email to your patients, right? So hit that button, email button, it sends it out. All right, so as we wrap up, we're almost done here. And let's see, we were under plantar fasciitis. We talked about kind of the symptom management, right? So early on, what are some of the modalities and stuff we can work on, right? So iontophoresis, phonophoresis, ice cryotherapy, like really those just working on either inflammation stuff or just making them feel better in the moment, right? None of those really work on the actual mechanics behind the foot, right? Hopefully we're all under kind of agreement with that there are people that get better with that's all they need. And because it wasn't that bad, they don't have that many mechanics. That's the person that, hey, you know what? I hiked for 2 hours yesterday for the first time in 6 months, and now my heel hurts, right? Maybe they don't have tons of impairments. It's just it was too much, too soon, too fast. Hey, rest. Let's work on just decreasing inflammation. And then next time, maybe train for it, right? Treat it as a marathon. So they don't need much. So there are benefits to it. Those acute people that are painful. The one I wanted to bring your attention to here is this taping, right? So if we're going to have someone that we've identified, you are a poor arch person, you lack supination, you have too much pronation, your muscles suck. When I correct it, right, when you did a squat and I fixed your arch, it felt better. How long is it going to take them to get stronger and learn how to create a good arch? Okay. Jayho's been working on it for probably a year now, and I haven't seen much change. I think it's a motivation thing on his point, though, right? So the nice thing about taping is there's a lot of actually good studies that talk about low dye taping. It takes a while to do correctly, right? There's lots of different components to it, but it's something they can wear 2-3 days that allows them to have good arch control. It puts their foot in an arch, and it actually helps them learn a little bit on what their foot should feel like. Doesn't make them any stronger, but it unloads that tissue. It prevents the plantar fascia from being stretched every time they go into pronation. It's kind of keeping it a little bit taut, which is good. So the person that is telling you that maybe they have something big coming up, right? Maybe they have something where they have to walk the next 2 days a lot more than normal or something. It allows you to, I would just say the hard thing in the clinic is it takes time, right? It probably takes a good 7 minutes to actually do that well, because of how many different strapping tapes you need, and you have to cut the tape if you need to, and that. So, but it's a good one. So, and the articles say they've compared it to like sham taping to see, is it just placebo? Is it just because you're putting tape on them? And they said there's actually, no, it's, if you do it correctly, you get good benefits of it. Hard thing is, take the tape off, doesn't mean all of a sudden they have a nice, beautiful arch, right? So just use it as in the moment for people that are pain. So it's still good though. Get rid of this. All right. There's another one that's just kind of the reverse 6, right? This one's nice because it only takes 30 seconds, right? You're just wrapping it around, start lateral, and then you pull up medial at the arch, right? And it just creates a nice little fake arch for them. So then they can go and they can practice their exercises. They can practice walking. They can recheck their squat to say, hey, it feels better. So I actually use taping quite a bit as an assessment. I mean, if I put your foot in this position and then we recheck it, and does it change what you feel? So then it tells me, yes, we need to work on strengthening. But how do you think the patient kind of feels about that? If I was able to make their pain better with this tape within 30 seconds, right, it kind of makes them trust me a little bit more, makes them buy into the intervention of, hey, we have to work on strengthening. It may take you 6 to 8 weeks, but at least they're willing to do it because they saw the benefits of it already, right? Sometimes it's hard to get people to commit to things purely based on faith of what you say. So we can prove it.
Dr. LeMoine, is that Leuco tape that you're using?
Yeah, Leuco tape. Yeah.
Okay.
In the reverse 6 one, it's supposed to be Leuco tape. We didn't have any at the moment, so I think when we filmed it, but yeah, in the low dye taping, definitely Leuco tape. So you're always going to put the cover roll on first, right? Put the white cover roll on underneath it, and put that on. Good. And all the instructions there, you can watch the video if you need to go over it. Cool. Okay. So I think if I go back to modalities, interventions, okay. So I think that is all of the main stuff. We talk about this as just a mechanical plantar fasciitis. What are the common impairments? What are the common key findings that we want to try to measure? Right. If I go back to this PowerPoint, right? So remember we talked about like the early phases. Hey, we could just work on symptom management, right? There's some really good things out there that talk about. So plantar fascia, people have had it chronically. It doesn't really get better that often, right? I think of it as kind of like a chronic lateral epi. People that have had it for less than 3 months, you can work on things and make it feel better. People that have had it for a year, 2 years, you can kind of improve it and they feel better, but it doesn't really seem to go away. It's kind of like this chronic thing. And there's some good things that talk about the tendon actually becomes very degenerative, right? You get this degenerative tendon. And so even when you're trying to rehab and model it, the tendon is not, this fascia is not it's not itself. So you can do all of these like short foot exercises and try to get all these different muscles to work. Try to get your foot to look like this foot in the middle of the screen, right? Look like my abs. Try to get into weight, but they talk about how even if you try to do all of these things, which is really good for the mechanics, and studies show that it decreases stress on the plantar fascia, which is great. A year later, if you're looking at ultrasounds of that plantar fascia, it still doesn't look the same as the other side. It still has this degenerative principle. It's almost like you're getting arthritis in your plantar fascia, right? It doesn't go back to the same, right? There's some really good studies on like these hamstring strains in athletes too, where they have a hamstring strain and then they go through all this rehab, they get back to playing, they pass every test, they get back, no issues whatsoever, 100% testing. If you look at like these ultrasounds of them, the tendon still has all this avascularization and all this chronic scar tissue, even though they have no issues with it, which is great, but it doesn't ever really go back sometimes. And so that's where, that's where if you guys have some time, this would be a really good thing to read. It just kind of came out earlier this month. It's not a research study, but he quotes over 15 different research studies, and he talks about a different side of plantar fasciitis. So instead of talking just about the biomechanics, which we just spent the last hour talking about, and how do we treat it, but that, you know, there's definitely this persistent pain, chronic pain aspect to why people have it for so long. And there's other ways to treat it besides the symptom management of icing, the mechanics of short foot and dorsiflexion, but there's this whole other mindset about trying to treat it. And it's from, it's just called Pain Science. It's a website thing, but the guy that wrote it, he tries to make it very evidence-based, even though it's just a blog. But I thought it was good. So cool. Okay.
Dr. LeMoine, we had a question. So if someone doesn't really have like a flexible flat foot, do you find that these exercises tend to help? Like all the
good. Someone that does not have a flexible foot or does have a flexible foot?
They do not have a flexible foot.
If they do not have a flexible,
like a rigid flat foot.
If they have a rigid flat foot, then I would want to make sure they can get into supination. So I would say these exercises won't work as well if they can't even get into supination, right? So that means maybe we need to work on pushing them into supination, right? So you may need to do some mobility treatment, right? And that would come down to when you do that oblique axis and mid-tarsal axis, right? Longitudinal oblique, right? It should be able to wobble and move, right? Right. So someone who doesn't have that mobility into supination, how are they ever going to strengthen into supination if they don't even have that mobility, right? So that's a great question. I would say majority of people though, if they are pronated, right, it's not normally a stiffness problem. It can be, right, but not often. Often normally the person that's stuck in supination, right, they're really supinated a lot, that's the person that kind of is stiff and they can't get to pronation like they should. And we may need to work on getting them into pronation because you need that for shock absorption when you walk. Right? Good. Okay. All right. So that kind of wraps up more than you might ever want to know about plantar fasciitis. Any questions, guys, or any comments about what you guys are thinking?
I have a question.
Yep.
What MMT do you do for the foot intrinsics? I know we kind of talked about that a little bit, but how would you give them a grade? Do you have a specific MMT for that?
I just grab all 4 toes, not the big toe, not the flexor pollicis. I just grab the 4 toes and I just try to almost like a neuro exam and just try to extend them. And then grade wise would be how you compare it to the other side. Like, hey, can they hold as strong as they can? And ideally you shouldn't be able to break someone's, if you do all 4 of them, you shouldn't be able to break someone's toes easily, right? Sometimes I think we take it easy when we're checking post tib or pronatus longus, or we take it easy because like, oh, it's the foot, right? But I mean, you should be able to crank on someone's anterior tib, crank on someone's posterior tib, and they put all their weight on it on one foot, right? At some point in gait, there are other legs in the air, and all their weights there, those should be strong.
Okay, got it.
Cool. Good question.
Let's see.
Can I ask a question, Dr. Norman?
Go ahead.
What are your thoughts on rocker shoes? I know some people recommend them, and I've even seen patients with success with it. I'm just curious, like, if it's something you would ever suggest us recommend.
You know, there is, I think it's like a level C now is what they gave it. But yeah, there is evidence that suggests this rocker bottom shoe where you kind of get to skip that true dorsiflexion where it pulls on your tendon phase and you just kind of rock through it. And it shows that it's beneficial for symptom management. So again, it's like an interim to unload stuff. So it's good. I don't necessarily tend to give it to them a lot unless it's someone who's going to continue to walk a lot and they're open to it, versus the person that can avoid it. Just because there's some studies about falls with rocker bottom shoes, so balance stuff if it's the older patient. But if someone who's asked about it, like you did, I'd totally be like, yeah, go for it, right? But I don't necessarily tend to bring it up per se. But if they bring it up, yeah, studies show that they're helpful.
Okay, because I was kind of thinking of it like similar to a modality. Obviously, they're not going to get stronger, but it'll make them feel good. But that helps a lot.
Yeah, but if you think about the that blog about the pain science, sometimes making somebody feel good and be able to meet their goals can really decrease pain quite a bit. So it's helpful. Yep. Good.
Thanks.
Yep. I was looking for where it is in here. Somewhere in here they talk about it. It's a grade C, but cool. Okay. Any other?
Someone asked about upcoming webinars. We're gonna be putting more webinars out, but our next one will be June 5th, talking about ankle sprains. So make sure you register for that, and if you have friends, fellow classmates, let them know about it, because we would love to have them join. But we'll be putting out another list after that as well, that we're going to be going over that.
I just wanted to add too that this was, we noticed there was a lot of APU students, which we love APU students. But if you are not from Azusa Pacific, we also love a variety and would love to hear what you guys have learned. So please tell your friends about the webinar, so we can fill this up even more.
Next week we're going to try to do 3 on every joint. Next week will be our 3rd one on ankle foot. So we're open to where we go next, whether it's hip or lumbar or cervical. So if any of you guys have a preference, obviously if you all throw out something different, we can't accommodate it. But if somebody has a difference of like wherever they would like to go, maybe I can make that the poll next week, or I guess so. Or maybe we can make a poll right now. Let's see.
We already got one lumbar. We got lumbar. So.
All right. So lumbar. Okay. So maybe then next week will still be foot, but the week after that we can go down lumbar unless it gets outranked for something else. But cool. Okay.
Going back to some questions, Levi had a great question. What if someone doing the objective tests, they have a lot of edema? How will that affect some of your testing?
I would say first I'd have to think about why do they have edema, because plantar fasciitis normally doesn't create edema, right? So I'd say if there's a lot of edema, am I missing something? Is it a fracture because there's trauma? Is it some type of other cardiovascular?
I mean, there was a lot of things going on, but she was very overweight. But I think that, I think what it actually was post-tib tendonitis, but then you had some plantar fascia stuff in there too. So I guess is more of just like a comment on, just how things can get kind of muddied when there's lots of comorbidities, and kind of how you would, I don't know, just any tips on, kind of sifting through the sand.
Yeah, that's good. I see the point on that then. So if we think it is a musculoskeletal thing, there's just lots of other stuff buried on top. You then start to say, okay, can I get something functional as my objective? So that I think someone earlier threw like a 6-minute walk or something, where it just gives us an idea of where she is regardless of the diagnosis. Oh, she has posterior tib and plantar fasciitis and edema and whatever else she has, and diabetes. Hey, at least I know this is where she's at. So I want to make that because all of the little tests are going to get muddied, right? Like you said, if I'm trying to check for plantar fasciitis, maybe I'm pulling on the post-tib. And as I'm trying to check for post-tib, maybe I'm pulling on her nerve. And so you try to find something functional that she's in control of as our baseline. So whether it's how many sit to stands can you do in 30 seconds, right? It's a good functional test, or the walking tester. So that'd be the first part. And then when we get to the on the table component where we're looking at specifics, right? You start to say, okay, how can I give percentages to these things? Because if it's someone like that, she probably has a lot of things you can work on, right? We can work on dorsiflexion, and we can work on post-tib strengthening and pronator lungs, and we can tape, and we can do all these things. I would say I start to create like a list a little bit of where is it worthwhile to spend my time? So at the end of it, hopefully I've made a little objective to say, you know what? I think 40% of her issue is that when she stands, she has all of her weight on her calcaneus. Everything's on her calcaneus. And 30% is she has no idea how to turn on her arch muscles. And the other 20% is when she stands, her knee dives in the femoral adduction and rotation or something, right? So if I can put a percentage to that, at least it makes it easy to make that choice to say, yo, I'm going to work on her standing posture today because that's where I put the most amount of my percentage. I don't know if that makes sense.
Yeah, no, perfect. Yeah.
And then this question will be like, well, why does she stand like that, right? Why does she stand like that? Do I need to work on calf strengthening so she doesn't stand so far back? I need her to be able to lean forward a little bit more in order to lean forward, you got to be able to hold yourself up with your gastrocs, right? So if you think about just maybe her body position, if she is a larger obese person, right? Do those people normally need to stretch a lot, or do they need to really work on strength and stability? Like, normally it's strength and stability.
Yeah, strength and stability.
Yeah. So it may be something, but again, you can't necessarily expect her to do these doming exercises at where she's at and everything she has going on. She's not the person that you try to find the needle in the haystack, right?
Yes.
It's like, hey, we're going to work on, can we just get you to stand better?
It's a haystack full of needles.
Exactly. There you go. That's a good one. That's a good one. Yes. How can you go in with a big, some type of construction thing and scoop out a big thing of needles?
Yeah.
Like cat claw, whatever. Cool. Good question. That's a good one, because sometimes we try to make it black and white with evidence. It's like, hey, this is what the research says, what the guideline says. As soon as you get to the clinic, there is no black and white, right?
Yeah, for sure.
Cool.
Dr. LeMoine, what's your experience using conservative care with heel spurs?
Say that one more time.
What is your experience with conservative care with heel spurs? So let's say they come in the clinic that, I got an X-ray, I have a heel spur.
Yeah, the nice thing is that a lot of people have, so I'll give them evidence. If they're really set in stone on that, I'd give them evidence to say, heel spurs are very, very common, right? It's like getting gray hair, right? It's common. Majority of people that have heel spurs don't even know they're there. So heel spurs can be asymmetric. What I don't tell them is you don't have a heel spur, because they probably have evidence that they do. What I don't tell them is that your heel spur is not causing your pain, because I don't want to go against their belief. What I tell them is, you have a heel spur, it could be causing your pain. The nice thing is, we don't have to get rid of your heel spur to make you feel better. Because that's their thought. I have a heel spur, I got to take it out. But what I can tell them is, no, lots of people have heel spurs and they're totally fine because of blank, because of they have good arch strength, they have good mobility. So I try to turn it to, hey, you and your heel spur can live lovely together, right? And then that way, because in the past I used to say it's not your heel spur, everybody has heel spurs, and it kind of would blow up in your face. You get this conflict. So now I've learned to, how do I fine tune it a little bit better? I'm saying, oh yeah, you have a heel spur. Nice thing is you can be pain free with heel spurs. They're very common. A lot of people have them and are pain free. That might have even been there before you had your pain. It's just maybe there's some rubbing. We don't need to take the heel spur out to make you feel better. Yeah, I think in that blog, that one that I put up there from the guy about the pain science, he lists some evidence about heel spurs and how common they are just in the population in general, as well as that. And so I'd say, now let's say it really is a heel spur that I think is causing it, right? His windlass mechanism was negative, all these things. Really the best thing is, how do you just calm it down? And that'd be maybe like a heel cup or something. Give him a soft, squishy heel cup to walk on. And hey, let's just get that to calm down. Treat it like a non-good slaughters. They don't go in and all of a sudden cut out the tibial tuberosity, right? They just let the bone calm down. But good question. All right. Anybody else? Are we good to go? Thanks, guys. Thanks.
Thank you, Dr.
Thank you,
LeMoine.
Dr. LeMoine. Thank you.
Hey, my pleasure. My pleasure.
Thank you.
Cool. I will see you guys next Friday. Talk about ankle. All right. See you guys.
You guys.